Hello, everybody. Welcome into night 2 of the 3-day EKG challenge. Hopefully you can hear me and see me okay. Everything look good? Okay, let me make sure I can share my screen with you guys. And I think we can. So let's go ahead and share the screen. So we're also going to go ahead and hit record and officially welcome in and good evening. We're so happy you're here because today is the day we do arrhythmias. And we know that a lot of you signed up mostly to do some arrhythmias. Now, we're not only going to uh, learn arrhythmias tonight, but you will most likely see them tomorrow night as well in a very special session by our wonderful coach, Michelle Barkley, who is on with us. Let's give Michelle a warm welcome tonight. How are you tonight, Michelle?
Got to get the off mute thing. Yes, doing great tonight. Excited. I've already started working on the game, so I've got some new questions in the game, and I think I'm going to do the EKG millionaire game tomorrow. So, who wants to be an EKG millionaire is what we're going to do tomorrow night. But
Okay.
new questions, so don't think you already know all the answers.
Yeah, she bases each game that she makes for night 3 on whatever I happen to talk about during the challenge. So she keeps it fresh for you, even if you've been here a couple times. And the cool thing is, Michelle is going to have the whole first half of tomorrow night, and she's going to not only do a game, but show you some tips and tricks that she likes to teach about. And I can just guarantee that it's going to be magical. So that will be a great way to warm you up. And then I'll follow her with our 12-lead lesson for the night. And we'll actually wrap up the evening by giving away a scholarship tomorrow night. So I'm really excited. So Michelle, as always, I know that we have a lot of fans of yours that come. And I know they're always hoping for just a little, glimpse of the heart voices. So maybe, if you're feeling motivated tomorrow night, we'll see. We'll see. So anyway, let's see. I think we're officially live and welcome in on Facebook and on Zoom. How was your day? Hopefully it was great. I will tell you that I think that the eclipse might have messed up some electronics today and yesterday. As funny as that sounds, there was a lot of tech issues everywhere we were. But Marcia says, I'm just hoping to develop my knowledge as it stands, and we will. Tonight's going to be good and juicy. So let's hop into it. So topic tonight, again, is arrhythmias, and we're going to try to set your heart on fire to make you as excited about arrhythmias as we are. Now, I have to just tell you, though, even though I love arrhythmias, there's someone that loves them more than me. And that is actually Coach Sean. So if you're in our 30-day EKG challenge, he teaches twice a month on arrhythmias. You've probably seen him, but he is actually more excited than me, if you can believe it. Okay, so also, I forgot to announce, yes, we have a winner. So hello. You just ate some tacos. All right, I want to eat some tacos. That sounds great. So remember yesterday when I showed you guys this kit and I said we were going to pick a winner. The winner was selected and it was Cheryl Elliott. So Cheryl, hopefully you're on. I'm going to need your address to put this in the mail to you. It has all the goodies that we normally send people who sign up for our 30-day EKG challenge. But you won this box full of the painting, the crayons, the workbooks, the tools, all the things. But if you didn't win a prize, don't worry, you're going to have another chance tonight. We are going to be giving away a badge that I will be showing you. So don't worry, you'll still have an opportunity. So congratulations, Cheryl. I hope you're watching. But if not, and you watch the replay, just message me in my inbox and give me your address so I can put it in the mail. I know, go Cheryl. So anyway, last night we did part of the workbook, and I know that my trusty assistant, Ruben, did put the workbook link in the feed for you here on Facebook. I believe he put it in Zoom as well. And so if you wanted to go along with us on the workbook, because we will have another page to do today, you can print it. There's still time. You can go ahead and Facebook and grab that link. And yeah. And so here's the answers. I also wanted to point out that the answers are also in the guides section in the Facebook group. Okay. So for example, this is in guide 1 for day 1. So the day one video is in there, and then the answer is in there. So don't hesitate to, even if you want to watch this later, you can do that also. So, and you have the answers. Yay. All right. So as I hinted to, oh, awesome. Cheryl just messaged me. She must be on watching. Hello, hello, Cheryl. And you're so welcome. Okay, so the 3 questions to answer, I alluded to this last night, and I really want to tell you that when you're interpreting arrhythmias, this is a really good set of questions to get you most of your answers. So the only other thing I would add to this, I think I'm going to add it for next time, would be, is a P wave present or not? So with those 4 things, you actually have your answers. So is it narrow or wide? If it's narrow, it's coming from the top of the heart. If it's wide, it's coming from the bottom. Is it fast or slow? And do we need to intervene right now? Is it a asystole? That's an intervene right now, right? Is it an SVT at 180? That's something we need to intervene on right now. A VTAC, we need to intervene, right? And then regular versus irregular, that's using that R to R interval that we talked about last night, seeing if it is a nice and expected timing and cadence, okay? And then looking to see if there's a P wave. Thank you, Michelle, for posting the workbook link in Zoom. You are amazing. And then now what we're going to do is switch gears a little bit, and we're going to jump into the atrium first. So that's the top of the heart. And we want to talk about some of the things we can see coming from the atrium. So there's a list here of some of the things. You can see AFib, which is very common. You can see flutter, you can see supraventricular tachycardia, you can see sinus tachycardia, Wolff Parkinson's White, PACs and PVCs. Okay, or sorry, PACs, not PVCs. So all these things can come, and they all come from up here. And so if we had to take a stab at what this rhythm, this first one here for us to interpret, what could you say about it? Is it regular or irregular? So type in the chat, is it regular or irregular? Yeah, it is irregular. Good job, everybody on Zoom and on FB. So knowing that, we got to answer our question also, is there P waves? Now, yes, Jessica, they are. Exactly. What a cool name, Jessica. And so I don't know if you're noticing, by the way, I'm watching the comment as I go through here. KJ is on here being supportive and wonderful. So KJ, do what KJ does, okay? Because follow that lead and you will be in the running to win the scholarship that we're giving away tomorrow night, because we want people to be supportive to their people who show up. We want you to encourage each other, which KJ does a great job of. So we're glad you're here. So going back, is there P waves? And the answer is, if you have to squint to see P waves, there is no P wave, okay? And that's what's happening here. Good job, Matt. Hey, Matt. Matt, oh, I'm so excited. Matt is here. I'm sorry, I will stop. No, don't stop. Please set a great example, KJ. And don't ever stop. We love your energy 100%. Petra, yes. Marcia, yes. No P waves. And it's fibrillating, hence the crazy baseline. Marcia, I couldn't have said it better. So thank you for filling in the blanks. And so therefore, this would be called a what rhythm? This is called AFib. Good job. This is AFib. And so again, irregularly irregular with no P waves is atrial fibrillation. Okay. So let's talk about some other things that we might see. So this is an example of what we want to see. Okay. This is the normal sinus rhythm. And yes, welcome back. Exactly. So normal sinus, you know, the sinus node is running the heart because there's a P wave, right? You've got a beautiful P wave. It's the same morphology, which means shape. And the QRS is still narrow. So this is normal sinus. The intervals from the R to R are regular. And this is pretty basic, but it's a regular R to R. Okay, so that's exciting. And then anything other than this is going to be not normal. So let's bring it. So here's a good one. This is a fun little one to, hello, Mikhail. It's better to be late than not come at all. So anyway, this one here is going to be one that may fool you into thinking it is atrial fibrillation. Because based on what we just said, if it's irregular, we might think that it is AFib. And this is indeed not AFib because we can see distinct, beautiful, I'm going to do red, okay? You can see there's a P. Absolutely no doubt about it, okay? So there is absolutely a P for every QRS. Okay, there's no dropped complexes, and there's just a little bit of a longer R to R than there is here. So this is a little bit irregular. Does anybody know what this is called? Does anybody know what this rhythm is called or what causes it? So yeah, potentially. So actually, you're onto something, Marcia. You're onto something. So breathing is what causes this, and the change in vagal tone creates this rhythm, which, as Petra correctly identified, as sinus arrhythmia. Outstanding job, and Mikkel, because there is a sinus, right? It's running the heart, but they're just breathing, and so that's creating a little bit of a R to R variation. So this is seen in younger patients that are usually athletic. They have good vagal tone, and it's not something that you're going to have to address. It's really a do nothing. There's another thing that we really don't do anything about that potentially can scare us too, and that's a first degree heart block. So a first degree heart block would be a prolonged PR interval over 200 milliseconds. And that's not ever going to be the cause of your syncope or anything else. It's something that you can also see, by the way, in young healthy athletes as a normal variant. Now, this is something we'll see all the time. We will see sinus Brady. In fact, we get referrals for these all the time. Oh my gosh, my patient's bradycardic. And so, how do we know that the sinus node is in charge? Because we've got a P wave. Here it is. Look at that P. Look at that P, look at that P. There's a P for every QRS. There's just quite a bit of distance between, and you could use the rule of 300 here if you wanted to see exactly what the rate is. This is probably going to be in the 40s. And so we can do a lot of things to cause this by things we prescribe. So if you had a patient like this, what are a couple things on the medication list you might look for? What are a couple things you might look for on the med list? Beta blockers, yay! Beta blocker. Okay. So, oh my gosh, I think we got a good question. Is there a rate that is too low for an athlete? So that's a really good question that KJ had, and you guys are all right about the beta blockers, calcium channel blockers, DIG, sometimes antiarrhythmic drugs like sotalol or amiodarone. They can also cause slow. Okay, so be careful about overprescribing because we do see a lot of syncope come in from being overprescribed, right? So, or maybe their kidneys are failing and they're not processing the medication out as much as they used to. So anyway, low rate for an athlete. So athletes do have efficient hearts. Lance Armstrong's heart rate is in the low 30s. So he just operates like that because his heart is so efficient. Now, I wish we could all be like that, right? We could all be Lance Armstrong. But the question has to become, are they symptomatic? And that's kind of how you make your judgment call on the athletes. So, but good job on that one. What is the rhythm here? Well, you can see there's a beautiful P for every QRS. It's a little fast. It is regular and it is narrow. So therefore it is Marcia and Mikel, exactly, sinus tach. Okay, so type in the chat, what are some common causes that can cause sinus tach? Because remember, we treat the root cause. We don't treat the rhythm really. It's coming because of something. So we saw this a lot in COVID, dehydration, me walking up too many stairs. Yes, me too. Infection, fever, pain, anxiety. These are all wonderful answers. And yes, sinus tach. This is absolutely sinus tach. So you got to think about also hypovolemia. That's a good one. What's causing it, and then fix the thing. And yes, caffeine is also an excellent example of why you could have this. But you always have to explain why. If you can't explain it, there's something most likely, unless you have like an appropriate sinus tachycardia, which is a whole nother lecture. But you have to explain it. And if you can't, one thing I just want you to keep in the back of your mind is pulmonary embolus, because PE causes unexplained tachycardia. And PEs are out there and they can bite you if you don't know what to look for. Tachycardia is just one of the things. Now, this is another rhythm that can bite you, but it's a very distinct rhythm. It is most often regular, but can be irregular. And what is this called? And are these P waves here? Remember, we're still in the atrium, and this is absolutely atrial flutter. You guys all got it. Those are sawtooth waves. Good job, Marcia. And they are not P waves. So the thing that I was referring to about this can bite you is because a lot of people don't know that you need to anticoagulate these patients if they have an elevated CHA2DS2 score and they don't have a high HAS-BLED score. We talk a lot more about that in the 30-day later on in the challenge, of course, but just know that if you see this, it's treated almost essentially like atrial fibrillation as far as a risk stratification for stroke. Yes. So CHA2DS2 score and HAS-BLED score, just a little side note, you can easily calculate that on a free calculator on, you can download it. It's called MD Calc. It's green with a plus on it. And yeah, Macal, okay. Was it Michael or Macali? You are getting in the spirit of cheering your fellow students on. So I have my eye on you. And so anyway, yes, all the things. So those are things we would do in the clinic, not EMS, exactly, KJ. We would be looking at their risk for stroke and deciding if they need anticoagulation. Okay, so that app again is MD Calc. I'll put it in the chat, MD Calc, and it's free, which is always good. All right, now moving along. Let's talk about this. You've already seen this tonight. Petra uses it almost daily. I know, same. Well, that's why you're with us, KJ, so you can keep learning. We got to keep it interesting for you. So this is, again, let's spot it. Let's name it. Oh, yeah. Look at you guys on Facebook. You are rocking it. Hey, Lisa. What's up, Lisa? Thank you, Michelle, for putting that on Facebook too. So it's irregular, slow, and yes, it is atrial fibrillation. Good job. I like the smiley face. So what is your patient going to complain of when they have AFib? What's like one common chief complaint you might hear? And I've literally, and as you type them in and what you hear when people have AFib, I'm going to tell you what I've heard. Okay, dizziness, Tammy said, palpitations, fatigue, shortness of breath, butterflies. I've heard that too. Butterflies are fluttering or bubbles in my chest. Weakness. I've also had patients complain of altered level of consciousness. And I think that might be due to the decrease in stroke volume, the 20% that you lose, the atrial kick. DOE, exactly, dyspnea on exertion. And the butterflies, yeah, I feel like patients, they don't read the same textbook, but they pull out the same answers sometimes. It's kind of crazy. Heart skipping a beat, shortness of breath. Jean said a good one. Tired, dyspnea. Yeah, these are all really good, you guys. So anyway, I got to tell you that have a low threshold for looking for AFib. And so hopefully you're doing auscultation, even if you're a medic, you're doing auscultation or a pulse check at the very minimum, right? To see if they're regular or regular. And if they're irregular, you have to explain why. So you need to make sure they're protected from stroke. You can't just say, oh, it's PVCs and let them go. You must get a 12 lead. All right, now we're going to move down into the junction. And yes, a good assessment finds the problems, exactly. Now in the junction, that's the AV node, that's like the middle of the heart. That's where things kind of slow down, but the impulsors are still going to be skinny here because it's still technically at the top. But really there's only two rhythms that you're ever going to worry about, and then one bit of ectopy. So you can have what's called a PJC, premature junctional contraction, and that is something that comes from the junction. But you can also have either just plain junctional, which is always going to be slow, or you can have accelerated junctional. And accelerated junctional is what you'll have a lot of times post-arrest after they've given epi or they've been resuscitated, a lot of times they'll come back with that. And then the temptation is to want to slow it down. But there's this saying in medicine that sometimes the hardest thing to do is nothing and put your hands in your pockets. And that's what we do with accelerated junctional, especially post-arrest. So anyway, that's not this. This is regular junctional. And you know that because there's no P and it's slow and it's regular and it's still skinny and narrow. So the AV node is in charge of the heart. Now, let's talk ventricle things. Okay, ventricular things. This is where we start seeing the uglies. So this one is big, bad, and ugly. Okay, this is idioventricular. And idioventricular is basically where you've got a wide complex, but it's still regular. And the rate is 20 to 40. So with that being said, 20 to 40, they may or may not have a pulse, right? And so this could be, if they don't have a pulse, be called PEA, right? But just wanting you to start identifying that exactly, KJ, identifying if it's wide or narrow, and anything over 0.12 or 120 is going to be considered wide. So bundle branches are something that can be wide. Wolff Parkinson's White can make it wide, but so can being in the ventricles in the idioventricular rhythm, right? And so basically what's happened is the sinus and the AV have died temporarily, potentially, or maybe forever. And this is what's taken over. So this is not a good thing to see. And then eventually, as one little lonely heart cell at the bottom of the heart is trying to run the heart, it's unfortunately not doing a good job. There's not going to be a pulse with this, and this is called agonal, anywhere from 0 to 20 beats per minute. So this has got a wide, bizarre appearance, and this is what happens right before they go into asystole, which is a flat line. Okay, so basically that's really bad. We also can have a rhythm that is this. You also can have this. This would be bad to see. So this is a fast, regular, wide. So you guys tell me in the chat, what is this? Marcia is our fastest type tonight. Fastest typer award. We should start giving that out. But yes, VTAC, everybody's agreeing. I love it. You guys are agreeing with each other. What about on Facebook? You think this is VTAC? Okay, awesome. In order to be really sure, look at you go, Matt. In order to be really sure, we would do a 12 lead, right? We would do a 12 lead and make sure it isn't something else like an SVT with the Barency. But we're always going to assume it is a VTAC. Yes, KJ's got a challenger finally for once that can type faster. All right. So the question would be, do they have a pulse or not a pulse? And if they have a pulse, then we're going to treat it differently than if they don't, right? But they're probably going to get either an antiarrhythmic drug if they have a pulse, or if they don't, they're probably going to get some Edison medicine, so a defibrillator. Use AVR. She is your best friend. Yes, Michelle's going to teach you all the things tomorrow night. I'm so excited. So what is this? This is basically anarchy. This is chaos in the heart. This is otherwise known as VFib. Yes, VFib. Good. We know that because it's coarse. A lot of people say, "Oh, I think that this is maybe AFib." It's not. We don't have enough, activity really to call this AFib, and it's consistent. And some people say, "Oh, it's torsades." Torsades looks different. It's more organized. This is just a, bag of worms baseline here. And this patient also needs to be defibrillated. And anarchy, total anarchy. The blood's not moving anywhere because nobody's coordinating together. We also have ectopic beats, right? Talked a little bit about the PJC. These are PVCs. We know that because they are wide and they are also different shapes. So when they are wide and different shapes, we know that they are premature ventricular contractions, but we also know they are multifocal, because they're different shapes. And the more PVCs you have, the more worried we are about you. All right, now let's grab our workbook out. We're going to go ahead and get our workbook out and do a couple strips. So we talked about this yesterday. These are just the answers. Hopefully you can read my writing. Some people say, "Oh, I need you to clarify one of the things." Hey, I know my writing is not great. Even my husband gives me a hard time. But if you have questions, let us know. I do. I know, totally, KJ. But here is day two's answers to give these to you, right? So you could practice. This is AFib. You have this in your workbook. This is an example of sinus arrhythmia. This is an example of idioventricular. And then you also have a junctional rhythm down here at the bottom. So these are all waiting in your workbook if you want to practice them. And sight rhythms we already talked about. So we talked about the VFib and the asystole and the VTAC. So we've covered actually a lot of arrhythmias tonight. Who feels more comfortable after tonight's session with arrhythmias? Who feels like they got like a little more confident? Type in the chat. Let me know if you feel more confident. In the meantime, we're going to wrap it up for the night, but we are going to be giving away a prize. I'll give it away tomorrow night on the live. I'll announce the winner. Actually, I think we're going to give away 3 of these tonight. So, yes, maybe a little repetition helps. Yes, I know. It's a start, right? It's an intro. Tomorrow night, Michelle will bring a few arrhythmias into her game, and that will help. But ultimately, it's practice. It's practice with help. It's practice under guidance with some mentors. So we'll be talking about the 30-day EKG challenge tomorrow and how you can continue on learning like this with us, where we have tons more waiting for you behind the scenes. Okay, so this is the prize. This is a badge with the STEMI mimics. Okay, and this is actually made by Matt Holden, who coaches in our 3-day and our 30-day. And we're going to give away 3 of these tonight. Well, tomorrow night, I'll announce the winners. I'll pop them in the mail for you, but these are so cool. These are limited edition. And he actually sold out of these for a while. I have a few of them, so I'll be giving them away. Super excited. So how can you win? Yes, from Scope Education, who is a really great guy and has lots of great free education. Follow him too, so you can. He posts like almost every day something really cool. Anyway, how can you win? So you can type in hashtag 30-day, hashtag 30-day in the chat, hopefully in Facebook. That's easier for me to find so I can select our winners. But we'll be announcing those tomorrow, just like we announced our winner of our kit. So Cheryl, I gotta go mail this for Cheryl. And yeah, these badges are just too cool. And so speaking of these STEMI mimics, he put them on here for reference, but the thing is it's great to have them on a badge, but you have to know them first, right? So that's the trick. You have to know them first. How do you learn them? Well, we happen to have a solution for you. We teach about all of these in our EKG workshop inside of the 30-day EKG challenge. So we talk about all of these because there was, as I mentioned and referenced last night, there was an article that came out November 15th, 2022, where they now have new STEMI equivalents. And we also have STEMI mimics that can fool us. And so we want to make you bulletproof so you always get the right answer. That's kind of our goal. All right. Yeah, he has another badge too. He absolutely does. Okay, I see all your hashtag 30 days, so I can announce the people tomorrow night. I think that's all the things. Do you guys have any questions? Because if not, we'll let you go. We're going to try and keep tonight the shortest night, but tomorrow night will be probably about an hour. So just plan for that, our last night together. If no questions, Michelle, do you have any final thoughts? Or anything you want to add about what they should prepare for tomorrow?
No, I was just going to type that in that I was making notes on my PowerPoint while you were teaching. So there may be some way new questions. So might go back and look over that EKG notebook.
Nice. All right. Well, guys, you're going to be in good hands with Michelle for the first half hour tomorrow night. So actually a different Zoom. There's a different Zoom. So we posted it in the event, but we'll be basically releasing it again tomorrow. So you'll be a different Zoom than you were the past 2 nights. And then I'll hop on about half an hour in after Michelle does some wonderful teaching for you. You guys are so in for a treat. And then we'll wrap up the night with some more 12 leads. So
Jennifer, Michaela Noyce has a question. If you have a STEMI mimic, do you still consult cardiology?
love it. Love it. Okay. So that's a really, really good question. So I'll give you the answer is unless you're, well, even if you're super sure, you probably should. Here's the scenario. So I was working in the clinic. Somebody came in with back pain that radiated to the chest. They took some Motrin and it got better. So the patient was relatively pain-free by the time they came to the clinic, but I got an EKG and the EKG said STEMI. So I looked at it and I know all of the findings like the back of my hand of, well, first of all, STEMI, and I didn't see any reciprocal changes. I just saw widespread elevation. I know the findings of pericarditis, the Spodek sign, the knuckle sign. I know all the things, right? And I was like, this is pericarditis because it got better with Motrin too. That's really atypical. But I was like, well, it says STEMI. I should probably run it by my doc because, ultimately anything that's a hot potato that you're not like super solid and comfortable on, or maybe you have, an EKG that's a STEMI and you want to make sure it's okay to cross it out, right? Um, the cardiologist was like, yeah, I think it's Burger. I think it is too, but man, that elevation in 2 and 3, which are contiguous, are so large. I'm gonna cath him. So we cathed him, and it was pericarditis. But these STEMI mimics make us nervous at any level that you work at, whether you're MD, medic, RN, PANP, right? It doesn't matter. But even though I knew the findings, I still consulted and that's still true, even for other things. So like, let's just say, you know, you have a patient and you know the answer, you know what you should do, but either thing you choose, there's going to be a bad outcome. Like AFib's a great example of this. So if you have a patient who has AFib and you have to put them on an anticoagulant because they have an elevated CHA2DS2-VASc score, and you know that they are older and that they potentially could fall, right? Or they could bleed, but the alternative is having a stroke, there's probably not going to be a good outcome either way. A lot of times I'll just get a name on a chart of a doc I talk to because then it's shared decision making with my doc and it's shared decision making with the patient also because we've educated them on all the risks and benefits. So it's really a good idea to I feel, and I teach this a lot of this in our 30 day, that it's not about us and our ego. And I can say that because 16, 17 years of doing this plus 13 years as a paramedic, I don't care if I ever look dumb or anything to anyone I'm working with. I don't care. What I care about is that my patient has the good outcome they need, right? And it's always about them. It's never about me. And so I do everything I can, of course, to be the most educated, to be the best provider I can. I study on my own all the time, but ultimately there's still going to be those situations where you should probably ask, and especially when you're new, I would really hesitate for you to call a pericarditis if you're not 100% sure. But I teach pericarditis like, I don't know, once a week almost, it seems like. So, I mean, it's literally back of my hand. All right. Okay, so let's see comments. I'm sorry, I got on a rant. No one's going to ever ask a question again. Okay, if the patient has AV block, oh, this is another good question. Okay, if the patient has AV block and on beta blockers, do we wait? Okay, so let's dig into that for a second. Are we talking about a first degree heart block? Because again, if their rate is fine, we wouldn't need to change their beta blockers. But what kind of beta, or are you talking about like a third degree or a second degree maybe? So let's just pretend that you're talking about a second degree, or maybe you can clarify. Okay, AV block type 2. So there's two types, right? There's type 1, the Winky block, and then there's type 2, the Mobitz. So I'm wondering what setting you work in because that patient type 1. Okay, so type 1s are hard because they are sometimes normal in athletes. You will sometimes see that. I know it's weird. I didn't know that for a long time. You will sometimes see Winky Buck at night when someone has sleep apnea, and the treatment is fixed the sleep apnea. So, but I would say as a blanket statement that if they do have a type 1, heart block, or I'm sorry, winky block basically is what we're talking about, I would get on the phone and discuss with, so if you're working solo and you don't have access to talk to a cardiologist, well, honestly, I would just send the patient to the ED if they're especially if they're symptomatic, and you're not going to make that call. Like you're not going to stop a beta blocker and hope that it works and then like leave them in a secondary block, right? You're going to go to the ER because they got to sort it out. So basically, how the decision tree is going to go at the ER is they're going to look at the meds, right? They're going to look at labs. They're going to get CBC, CMP. They're going to get troponin. They're going to get magnesium. They're going to look at the meds for any rate limiting agents. So like an antiarrhythmic, so beta blocker, calcium channel blocker, antiarrhythmic drugs, and they're going to also get a TSH. So if all those are fine, basically they're looking for reversible causes and also how symptomatic is the patient. So if they're not symptomatic, it sounds like the heart rate was in the 60s. So first of all, I would question that they really are a winky bach, but I'm gonna send that to the ER. That's too high risk to just hope that the beta blocker is causing it and let them go. That's bad, right? Bad, bad, bad. So if you have a hot potato, ER, that's what they're there for. And I can say that because I work ER as well. But that's kind of the decision tree that you would go through. And sometimes what we'll do with those patients is we'll just sit on them and watch them. So we had an interesting case today of somebody who was weak and lightheaded and came in with a heart rate of in the 30s. And so the first instinct was, and he was older, and he had a little bit of vomiting. Okay, so he had a colonoscopy. He was vomiting. So the question was, does he need a pacemaker? Right. Okay. So we had to think about, are there reversible causes? Well, one thing you also have to think about is, was he potentially dehydrated? Was he also maybe had increased vagal tone from the vomiting? Um, what else was potentially going on? He wasn't on any rate limiting agents. All his labs, including TSH, were fine. And he didn't have any chest pain because you also worry about ischemia with a Brady, but and the Brady was not when he was sleeping, because a lot of times you'll see Brady when people are sleeping. And of course, you always think like, yeah, when that happens. Although athletes can get pretty low at night and we give them a pass if they're athletic. But if somebody goes like under 40 at night, we're probably not going to give them a pass. And we're really looking hard at sleep apnea. So figure out the why exactly. Does anyone else see beta blockers withheld because of low BP and then the patient's rate control is thrown? Yes, we do see that. So if you're ever going to be messing with a beta blocker, the best answer is to titrate down. You never want to cold turkey somebody off a beta blocker. It can cause that rebound tachycardia, and then patients are really upset. So if you want to create a lot of work for yourself, cold turkey somebody out of beta blocker, as you're probably alluding to. I know this is a great platform for us to educate on that, Marcia. So you and I, right? And it's usually post-op. Yeah. So I think that I wish I could stand on the rooftop as well. But these are great questions, as KJ mentioned. Let's just check Facebook. Is there any other questions? I don't see any. But yeah, that was really fun to talk through kind of the thought process. So if you have questions, bring them tomorrow night. We'll be here again. And Michelle actually really loves questions. Um, so don't hesitate to ask her tomorrow too. And she loves engagement. So the more engagement you can do with Michelle tomorrow, like the happier you'll make her. And she just lights up like a tree and the teaching gets even better. So anyway, yeah, don't hesitate to ask questions. Loving the interaction. And I can tell that there's a lot of like higher level thinkers in this group. And that really excites me. So I love how you're thinking. Keep it up, guys. We'll see you tomorrow. The replay is going to be on the replay page. It's also going to be in the guides. We'll have the replay page. It's actually already out, but this will be loaded on by tomorrow. So thank you guys. We appreciate your time. And again, I'll be picking out 3 badge winners and we'll talk tomorrow. I'll see you then. And please sleep tight tonight. Be safe and we'll see you tomorrow. All right. Bye, everybody.